Okay, enough from me. It's now my pleasure to welcome Jen Kaiser and Danelle Hawa Pendergrass. Jen Kaiser, MD, is an assistant professor of obstetrics and gynecology and a family planning specialist. Her clinical interests include contraceptive care for patients with complex medical issues, prenatal care, gynecological care and surgery, miscarriage management, and in-office procedures. Her research interests are varied and include contraceptive counseling, mifepristone use for miscarriage management, adolescent contraceptive care, and improving reproductive life planning for women with substance use disorder. She's originally from Wisconsin and loves gardening, cheese, and being in the outdoors. Danelle is a Carbon County native who returned home to fulfill a lifelong dream of caring for women in her community. In 2012, she opened Eastern Utah Women's Health and offers services to over 20,000 under-resourced women living in Carbon, Emery, and Grand counties in Utah. By partnering with local, state, and federal agencies, Danelle ensures access to healthcare for all women. And now, Jen and Danelle, the stage is yours.
Wonderful. Thanks, Jamie, for that introduction. I'm going to see if I can get my screen share going. Okay. All right. So as Jamie introduced us, we are going to be talking about family planning for people with opioid use disorder. And really, I think one of the big takeaways from this is going to be just to meet them where they are in this type of care. So for a brief overview, we are going to kind of review some family planning best practices in regards to this population, specifically with scheduling tips, method eligibility, and some counseling. And we're going to try to spend the majority of the time today actually on an interactive segment we're calling Check Your Bias. And we're going to touch a little bit on kind of what your patients bring to clinic. And then also we'll have a couple of clinical vignettes where, as Jamie said, we'll be able to use the annotate function, and we will be having some polling there too, and then hopefully have plenty of time as well for questions. So our key takeaways from our talk today, really big one, especially in this population, but really in all of your populations, is just to avoid coercive counseling. Make sure that you're checking your biases when you're walking into a room and you know that this person is a substance user, or maybe you're finding it out as you're taking their history. Be conscious of those. And then also support them in what they need, no matter what that is. Maybe it's prenatal care, preconception care, contraception, adoption, or abortion. I'm going to hand it over to Danelle for a moment.
So in an ideal world, we would definitely want to have walk-in clinics, right? Because we're meeting them where they're at. They have a whole different sense of time, sense of urgency. If they are showing up or calling your office, they are taking that initial step in getting into care. Now, I know that does not always happen, and it's very difficult to run an office on walk-in appointments, but maybe saving some time for those, for our women who are using substances to get in to get that birth control because they're thinking about it right at that time. Another ideal world issue is same-day inserts. If you can insert their implant or IUD on that same day while they're there, that is just best practices in contraceptive care. But it's also, if they're choosing that method that day, they want it, and you might not see them back just because of the nature of the disease, right? They're in, they're out, they're thinking about it now, they might not be thinking about it later. And also, so my world, is, many of you may or may not know, is unicorns and rainbows. And I always believe that we can do things better and have available supplies for everyone. So it's very nice if they are at your office and you do have your contraceptive method of their choice on hand. So they can walk out that day, either starting that method or having it in their hand to start when they get home. So that's great. the real world, people really need after hours appointments, weekends, and to be able to reschedule those no-shows. It's a difficult, it's difficult to get people in recovery and also those using substances within our little 9 to 5 narrow time frame of scheduling. Oftentimes they have a job or two. If they're actively using, sometimes they don't get up till 4 or 5 p.m. So just having the different availabilities for scheduling is really ideal. Now, that being said, I I run a clinic. I understand how difficult those are. But if we're talking ideal world and the very best that we can do for our women who are using substances, these would be it.
Okay. Oop, here we go. So I want to take a couple minutes and just talk through medical eligibility and also some considerations in a population of people who use opioids. Oops, sorry. There we go. So this is just a reminder and a little plug that the CDC has this really handy app called the MEC, or the Medical Eligibility Criteria. It is free. I encourage you to download it if you don't already have it. And what this does is it gives you kind of a quick glance overview of what types of contraception are acceptable in certain situations. So in this instance here, we're looking at people who are more than age 35, over age 35, who smoke more than 15 cigarettes a day. And ones and the green means that there really is not a lot of risk with using that method in this medical situation. Twos would be benefits still outweigh risks. 3 is that risks are starting to outweigh those benefits. And 4 is a pretty hard contraindication. Although there is some wiggle room, of course, in this as well. And so here you can see the combined hormonal methods in people who are over 35 who smoke is not recommended because of blood clot risk. So this is a handy tool to use if you have somebody in front of you. The other thing, sorry, my mouse is being wild. Okay, so the other thing on this app too that's really handy is this selected practice recommendations, or SPR. And this will give you good overview on timing of method initiation. So like Danelle was just saying, it's really great if like you can quick start a method, which is where you're providing that method and they're starting it the same day that they see you in clinic. And so here are the SPR gives you some great overviews for how to be reasonably certain that somebody is not pregnant in order to have them start the method of their choice that day. So some special considerations in this population. There are some unique comorbidities that have a little higher prevalence among this population. Cigarette smoking, we just spoke about that a little bit, and clot risk with estrogen containing methods. Also, mental health conditions really do go hand in hand with substance use and abuse. And so thinking about if somebody has depression or anxiety, and being able to speak with them about effects or non-effects of birth control on their mood disorder. And we'll talk a little bit about medication interaction as well, depending on what medications they're on for those mood disorders. And then of course, viral hepatitis and HIV positivity as well in this population. We'll talk a little bit more about those in a moment. So viral hepatitis and cirrhosis, during an acute flare of viral hepatitis, it's probably prudent to avoid estrogen-containing methods. If they have chronic hepatitis or they're a carrier, there's really no restrictions on the type of birth control method that they could use. And then in cirrhosis, so if somebody has mild cirrhosis, where they're not really having many liver abnormalities and the function seems to be fairly well intact, again, there's not really any restrictions as far as the type of birth control method to be used here. However, if somebody has either severe cirrhosis that's compensated, and especially if it's decompensated, you'd likely want to avoid using any estrogen. And the main reason behind this is because estrogen is metabolized in the liver. And if your liver is not really functioning, you're probably going to end up with a much higher circulating level of estrogen than you want, which again can run into all of those side effects that come with estrogen, like clot risk and things like that. Progestin-only methods, there is some controversy around this. Again, in terms of like, well, if their liver is not really processing the oral progestins, like, do you, like, will you have like too much progesterone around? Yes, but on the other hand, like, a lot of progesterone around is probably not that dangerous. I mean, when people are pregnant, they have a ton of it. So, again, I think the progestin-only methods are probably just fine, as far as like systemic ones. And then, of course, your non-systemic methods and barrier methods are okay to be used in severe cirrhosis. So HIV positive status, they can use a whole range of methods. There are some antiretroviral therapies that have some interactions with contraceptives, and so especially with oral contraceptives. And so if your patient is on, a heart regimen, just looking that up to make sure and see, like, is there any interaction here would be prudent. And then I just want to make a plug that IUDs are safe in this population. I think that there's some misperception out there that if somebody's HIV positive, they can't get an IUD because of risk of pelvic inflammatory disease. There is some really great literature out there that demonstrates that IUDs are perfectly safe in people with HIV, and that even people who have AIDS with low counts are still can still get an IUD with very low risk of PID. There's actually even evidence, particularly in the hormonal IUDs, that they are actually protective against PID. And so I think that these are completely reasonable to offer to your HIV positive patients if this is what they want. So a few more special considerations are just some drug-drug interactions. For our populations that are using opioids as their drug of choice, whether prescription or heroin or other, there's really not any drug-drug interactions between the opioids and any kinds of birth control, so there's not really anything to worry about from that standpoint. However, we were just talking about a lot of some different comorbidities, and this is where mood is going to come back into this a little bit. If somebody's on an anti-epileptic or an antipsychotic, there are some interactions there with birth control. And so this is a lovely table that I have tried to internalize and memorize so many times, and I still cannot do it. But these are the anti-epileptic drugs, and whether they are a CYP inducer or a non-inducer, making everybody think back to their medical school or NP school or whatever PA school, to the CYP pathway through the liver. And so the strong inducers here are actually going to decrease the effectiveness of your birth control method, whereas non-inducers, there is no interaction, and so you would be safe to use your oral methods here without any concern. Things that are non-oral, so Nexplanon, the NuvaRing, the patch, there is still some evidence that these inducers are still going to affect their efficacy. Nexplanon we're still trying to gather some more data about that. And so if you have patients who are on any of these in strong inducers, you may want to counsel them about using, again, IUDs are kind of a first line here where you're not wanting to have any drug interactions. And then the other key thing too here is that lamotrigine is kind of like a little bit of an opposite one where it will, the estrogen in the pills actually will decrease your drug level. And so just making sure that anybody who is on particularly over 200 milligrams a day is aware of that and that their levels are being followed if appropriate. And then finally, antipsychotic drugs. So amitriptyline, nortriptyline, those are like the TCAs, and the monoamine oxidase inhibitors. These may decrease systemic contraceptive efficacy. So again, something to keep in mind. Things like IUDs, depot, barrier methods are preferred. And a side note about depot, because it is such a huge dose of progesterone, it really doesn't, you can probably give it for your anti-epileptic drugs as well that are CYP inducers, just because there's so much drug around, it's still going to work. So just a couple take-home points. There really are few limitations in some of the more common comorbidities in this population. And then just, again, keep in mind drug-drug interactions. Look it up if you're like, oh, I think I remember, is this one of those? And make sure that, you're offering the patient something that is going to actually be effective for them when taken in at the same time as their other medications.
All right, here's our interactive portion of the presentation. So remember the annotations options where you can go up to the top of your screen, view options, scroll down, and hit annotate. And so the question I have for you are, so what are the best practices in a contraceptive visit? If you guys just want to hit the annotation button and type in what you think are best practices.
I think you can change, yeah, the size and font and all of that too, because I think it starts off pretty small.
Right, so we have one on here addressing their concerns, of course. Ask what the client wants. That's pretty good. Great open-ended discussions, excellent. Evidence-based information, giving them what they need. Avoiding stigma, excellent. Yeah, what's their priorities? Do they need something that's super effective? Do they want something to prevent pregnancy for a long period of time? Relationships, trust, respect. There's lots of misconceptions out there, right, about which methods work in which ways. Absolutely. Side effects, anticipate and address barriers, good. Okay, that's an interesting one. Dual protection is needed. So dual protection is like, do they need to protect from STIs as well as pregnancies? Sure, and what are the benefits? What are the benefits of using a contraceptive method? Okay. And getting a comprehensive health history, absolutely. So we know what methods will be the best for them. Side effects, wonderful. What the patient wants. Excellent. So these are all best practices. And guess what? They all apply to women who are using substances. It's all the same thing. But in doing that, let's see, how do I get out of my annotations to switch?
You got to click the little red X. Yeah.
All right. Can you
advance the slide?
Mm-hmm. Thank you.
Ooh, how do we?
We know how to do this.
Oh, we know how to do it.
Yay. So the cornerstone of counseling is to build that relationship, right? Because these women are coming into us, trusting us with their health care, coming in a vulnerable position because we may or may not know they're using substances. So we need to build that relationship with them. And, you know, contraceptive counseling is based on that relationship, that trust you're building, your expertise, how you answer their questions without judgment or flippantness. Like, you just want to build that. And as you're building that, you need to use your words. And that means avoid stigmatizing vocabulary. And so as we start to think of those stigmatizing words, it's like, oh, how long have you been an addict for? No, right? How long have you been using substances? Or how long have you not been using substances for? How long have you, when was the last time you were screened for STIs? Just, you know, just those things that don't put that extra stigma on them because they are already consciously aware of what's going on. And the hardest thing is when people come in who are using substances, who are using that stigmatizing vocabulary, oftentimes we need to give them permission to not use that anymore. We say, we don't use the word addiction here. This is a disorder. This is something like diabetes. And so we try to explain that to them just so that they know we understand where they are. And again, we're meeting them where they're at and making them feel safe and comfortable and open for discussion. Next slide. So counseling, again, go over all the methods. Like let them know what is available, look at their health history, and then use that shared decision making to decide like, hey, I know you really wanted to use the pill, but you have cirrhosis, or I know you really wanted to use the patch, but the medication you're taking right now is not going to work. Also, lack of method. Like, what if they don't want to use a method? Okay, don't use a method, but we're supporting them in that decision. And we're educating them about that decision. Also use your motivational interviewing. I mean, you guys are all experts at this. We all do contraceptive care. So how well are you doing things daily? What would this look like if we incorporated it into your lifestyle? What's most important to you about a method? Is it something that you know you're taking every day so that you know you're taking it? Or is it something you just want to put in and forget about it because life's a little crazy right now? So, using those motivational interviewing skills to say, okay, great, you're choosing the pill. How do you think you're going to remember to take that? And let them tell you what makes sense for their lives. And then getting consent. So consent, if they're fully lucid and haven't used substances or anything like that, is really easy. You get a consent for an IUD, big deal. But when they are when they're using substances and cannot make that conscious decision, sometimes you do have to wait. And that's nothing we want to do, but we need to make sure that they're fully present to consent. And that's always a tricky one. And then counseling. Just be prepared. Be prepared. Because again, I live in that ideal world where we're screening everybody for substance use disorders when they come in for their contraceptive visits. So if you're prepared to address that, then that takes that whole stress off of you and your staff. And oh my gosh, what do we do? This patient's using and they actually want help. So get your referral checklist together. Like get the people who will do MAT treatment if that's what the patient is seeking. Who are your counselors? Who are your therapists? Who are your go-to people? What groups are available for substance use disorder? Who can you send them to? What supports are out there? In Utah, we have USARA. It's peer navigators who can help them navigate into their recovery and throughout their recovery. So get that written down. Get that available, make it easy, make it a handout, make it a text, make it an email, and build those relationships with people outside of your practice if you are not providing MAT in yours. So you're serving both the client and you have a streamlined approach to helping them get the help that they need. And of course, our counseling take home. And we're going to dive a lot deeper into this, but avoid coercive counseling. Just because you might think that they need an IUD because of what they just told you doesn't mean that they want an IUD. So I'll save all the juicy stuff for the next few slides, but build that relationship. You guys are excellent at it. This is what you do. This is what you chose. Take the time to build that trusting relationship. And you're not only going to help them choose the right contraceptive method, you might be that instrumental person that helps them to seek out recovery, to finally go to that MAT clinic, to finally get into that counselor, or to have a healthy pregnancy while using substances. Either way, you're that person for them. And always be referral ready. Takes the guesswork out of everything, takes the stress out for your whole staff.
All right. Thanks, Danelle. So we're going to move into the interactive vignette portion of our chat tonight on checking your bias. So we're going to do a little fun word cloud again. So now that everybody's familiar with the annotation, we would like you to just drop some things in here about what do you think the fears, worries, and hopes are that our substance using patients bring to their reproductive health visit? Yes, that they'll disclose their drug use and that, yep, we're going to call the police, or if they, you know, have a child or if they're pregnant, that DCFS is going to come and take their kids. Judgment. Mm-hmm. Parole, yeah. Cost. Being embarrassed, that's a great one. Yeah, like, you know, just the embarrassment of disclosing, you know, that they are using or have used in the past. Yeah, previous negative healthcare experiences. Mm-hmm. Yeah, having, you know, internalized biases against themselves, right? Not thinking that they should be a mom. Yeah.
Oh,
Forced. Go, Danelle.
That just caught me, forced into a form of contraception, right? Just kind of what we talked about.
Yeah. Anybody have any hopes they think they bring? Yeah. Yeah, they'll have a provider who's listening, getting help. Mm-hmm. Regain some control. Yeah.
Mm-hmm.
Yep. Right. Being her understanding. Yeah. Great.
Good one.
That's a really good one. And hopefully we can all be empowered to provide more of these hopes to them than these fears and these worries. Great. Thank you all for sharing. Clear that off. Thank you. So in this discussion part of this, we want to lay some ground rules up front. You know, we recognize that examining our own biases is a difficult and very personal journey. And we respect that you have your own experiences and values, and we ask you to engage just openly and with non-judgment of others on this call. And then, you know, we are going to be using some polling, and that's going to be anonymous. So we hope that you'll participate in the polling, but we'd also encourage you to share your perspective in the discussion. And then these vignettes are intended to stimulate further some self-reflection on your values and biases around patients with opioid use disorder and reproductive care. So in the calendar invite, the registration thing for this talk, we did include some questions about values clarification that hopefully helped you just to think a little bit more on kind of personal and outside influences on how you approach patients with opioid use disorder. Also had you kind of reflect back on prior patient experiences. For anybody who completed that, I don't want to put anybody in the hot seat, but if anybody is willing to share, please unmute yourself. Let's go back one. Sorry about that. Please unmute yourself and just kind of, if there's anything that sort of surprised you or that you learned from this pre-workshop questions, we would love to hear it. And if people didn't get to it, that's also okay. I would encourage you to go back and look at that, the email after this session too, just to kind of help you reflect a little bit further on that. In the interest of time, we will continue to move on. All right, so vignette number 1. So there's a 24-year-old who's come to your clinic seeking contraception. She's an active heroin user that she injects, and she's also smokes meth. She is not interested in starting maintenance therapy. And again, she's here for contraception. So this is going to be a poll. What is your first instinct for the type of contraception method to recommend? Okay. I think that's just about everybody. Great. And so you can see here in the results a little bit of some mixes between, we're split kind of 50-50 between a LARC method or whatever they want. And I think that what's interesting about this one is especially is really thinking like first instinct, what do I want to like recommend to this patient when they walk in your office? What is that method that you're like, you should really think about X method? And, you know, I think that it is a very common thing to do that. I know personally, like I kind of have in my mind what I think everybody should have, right? And it can be hard sometimes to turn off that voice in your head in order to really give the space for the patient to explore their options and what they would like and what they need from a birth control. Would anybody like to add at all to the discussion on that? If like you've had some experiences in the past, or you know, like how you would maybe help yourself kind of overcome that initial instinct? Okay, quiet group. I helped to teach a small group session at the medical school here, and it's also all on Zoom. And I've developed a really comfortable spot with just silence until somebody wants to talk. So we may try that again a little bit later, but thank you for sharing on the poll. All right, we are going to move to the next one. Okay, so this is going to be a series of 3 patients. They're all coming to your clinic in the first trimester, and they are requesting prenatal care. And what I want you to do, so I want you to go with that first gut reaction to each patient becoming a parent. 1 means that you're very comfortable with them becoming a parent, and 5 is like, this makes me very uncomfortable, and it's going to be a Likert scale, so 1 to 5. And so again, I want you to go with that really that like first kind of gut reaction to this. Again, we're all here together in an open space. And so I hope that you don't feel that we are judging by anything that we are going to say following. So the first patient, this is Kristen. She's 19 years old and is an active heroin user with an unplanned first pregnancy. Her partner is 32 and is also an active heroin user. She plans to cut back, but isn't interested in maintenance therapy at this time. They have unstable housing and are both unemployed, but they are planning to parent. So again, that first gut reaction that you may have. we've got everybody in there again. Yeah, I'm with you. I am with you for this one. This one's really hard. Does anybody want to share like kind of what the key things in this vignette are that just like kind of puts that factor in there?
Well, I'll say that the fact that she's not interested in any maintenance therapy and they don't have stable housing, that makes me nervous.
Yeah, absolutely.
It makes me nervous because they're both active heroin users, and it doesn't say like if he's interested in cutting back or anything like that. So it's a uncomfortable situation for that baby.
Yeah, and is Kazi has added to in the chat, like who's going to take care of this baby when they're both using? Yeah, I mean these are, you know, real concerns for sure. So how then, so with this like uncomfortable feeling about this, like what are some ways that we can, you know, kind of look inwardly at sort of that gut reaction that we have in this instance to find ways to support these young parents?
I mean, I think like recognizing that any kind of big change takes a lot of time and just leaving the door open for conversations in the future. So not just being like, oh, she's not going to change her behavior or anything like that. And recognizing that just because she's not ready for MAT like right now, that it's going to be off the table in the future. And again, just like finding those things for her that are like really positive or that she's really looking forward about parenting, and kind of see how some of those things might be really difficult with some of the other stuff she has going on right now, and then trying to use the things that she's really looking forward to about parenting to motivate behavior change.
Yeah, thanks, Amy. Those are all really great points. I think leaving that door open, laying some groundwork from the very beginning of like, you know, but in a very non-judgmental way, right? You don't want to be just like right out of the gate and like, well, you really need to consider maintenance therapy. Like clearly, who's going to take care of your baby? You know, but more so of that, like, I'm here to support you in this, and laying that groundwork for readdressing it kind of visit after visit and seeing if there becomes more interest in the future. Danelle, I don't know if you have other thoughts on that too.
Well, I think Kazi just mentioned it in the comment to connect them with those resources. Like, again, get your referral checklist in order because this is going to come up. And you want to make sure that anytime she changes her mind, if she would like to increase access to services, or you never know when that may happen, be ready for that to occur and be ready for your gut check as well, because at first it takes you back and then like you need to be there for them and have that.
Okay, great. Let's, in interest of time, I know it's going fast. We're going to move on to patient number 2. So again, same thing, first gut reaction here on comfort level. So Maria is 34. She's a recovered opioid prescription pill user who's currently on methadone. She has been in remission for 11 years. She has a stable partner, job, and housing. This is a planned pregnancy and their third together. Okay, so this one, right? And we did this intentionally to put two very different ones side by side, right? And I think that the reaction to them kind of explains itself here. You know, I think everybody's like feeling pretty okay with this one. So what are some of those things that are different in this case that make you feel like this sounds like a great plan?
I think the biggest thing for me is that it was a planned pregnancy.
Yeah, do you mind expanding on that a little bit and how that differs from the unplanned pregnancy in the previous one?
I think when you have time to discuss with your partner and say, okay, I think we're ready to add another kid to the mix, then you're thinking about more than just the here and now. You're thinking the long term, and I don't know what I'm trying to say, but that's a much better scenario to me.
Yeah, kind of coming at it from, and Amber put in the chat, like the word stable makes you feel better. And I think that's kind of getting, Jennifer, to your point there too, of just like, they've talked about it. It's a considered, like, well thought out decision about adding another child, versus just like, oh, we got pregnant and here we are and we want to parent. And that stability isn't maybe necessarily there. Other things too, I think about that difference, and this is something that I personally struggle with a lot, is that seeming dichotomy between planned and unplanned pregnancy, and not just in the setting of people who are using substances, but kind of overall. I think it can be really easy, at least for me, like my internal biases here is like, oh, this is an unplanned pregnancy, like what a disaster, right? But I think we've all had those experiences with patients who are very thrilled about this, even though the timing might not be great. They might not have housing, they might not have a job, they might not have all these things. And so that's another spot too, where I always need to like take a minute, check myself on this, and be able to support them in moving forward with their pregnancy if that's what they wish to do.
Amy, I love what you said in the chat. Literally thinking of it as a chronic medical condition. It's clear it's well under control, and just like what we would do with somebody with diabetes. So yes, that's an excellent way to look at it.
Agreed. Okay, we're going to go on to our last patient in this series. So Kaya is a 27-year-old heroin user that has been on and off maintenance therapy over the past year. She has 2 children that are in foster care. This pregnancy was the result of reproductive coercion in which her partner sabotaged her birth control, but she is planning to parent. She's hoping this will help her stay on her maintenance therapy. Great. This is so interesting because we have such a mix. Would anybody be willing to share their viewpoint on this? It looks like we're mostly coming down in this middle range of like not really sure to like somewhat comfortable to somewhat uncomfortable. And that's such a gray area. I'll give another couple minutes if anybody wants to chime in with like what in this scenario is just like, I don't really know. I'm like on that fence.
I think I'm on the fence because she's hoping that being pregnant will help her stay on the maintenance therapy. So like there's a chance she could still fall off the wagon. And so it's hard to say, hey, maybe this baby is the Band-Aid to this long-term disorder that I'm struggling with. So.
Mm-hmm.
Cassie in the chat says nothing about this makes her feel comfortable, especially her hope that having this baby will help her. Very unpredictable. Agreed.
Mm-hmm. Mm-hmm. I mean, and I think we've all probably had experiences in the past too, right? Where patients say this pregnancy is going to help me in X, Y, or Z way, right? And I think that as a provider, that is a very uncomfortable spot to be put in, because, you know, we've seen those situations where it doesn't turn out like that. And it didn't actually help, or it maybe made the situation worse. But I think that in these situations too, it's important to keep in mind about not discrediting this as a potential way for her to like maybe stick with it more. And especially if like you are there to support her in this and give those resources and give that you know, kind of constant cheerleading from the sideline or whatever she may need to help support through this. You know, I think that it's hard to not be jaded after experiences as a provider where you've seen this not work a bunch of times. And that, you know, again, is a reason to kind of think on these scenarios a little bit more. And Jamie added too that, yeah, worried about, you know, reproductive coercion could be tied to other forms of intimate partner violence, and that is absolutely the case. And so, you know, another really important thing in all of these scenarios too is screening for intimate partner violence, and especially if somebody discloses, you know, that like they're pregnant because their birth control was sabotaged, you know, making sure again that the support and the resources are there, and that this is something that you're addressing kind of each visit with the patient.
Jen, I would just like to just draw some similarities. How many clients have we come in with an unplanned pregnancy who has all of these hopes for how this is going to make their life better, how this is going to make their marriage better, how this is going to XYZ. So it really occurs both in people using and not using, but for some reason, with those who are using, it really gets your gut checked, I guess you could say.
Yeah. Okay, we are going to move on because we are starting to run out of time. I think we're just about there though. So this third vignette, we won't spend too much time with. I'm sorry, because the poll has a lot of options to read through. But essentially what we're asking here, so you're seeing a patient who's addicted to prescription opioid pills for contraceptive counseling. She saw one of your partners a month ago for contraception and was told that her only option was an IUD, which she doesn't want. So she's here to see you for a second opinion. And so personally, what do you feel your professional obligations are to this patient? And this is a select all that apply. So I'll give you a minute here because it does require some reading through, and I'm sorry it's so wordy. Okay, you all are amazing people. And, you know, I think you can see here just kind of scrolling through, you know, where people are falling on the spectrum that, you know, like it's our obligation to talk to them about all their options, you know, provide factual information, refer if you're not willing or able to provide. And then, you know, everybody who answered this poll said that they are obligated to provide whatever contraceptive care they need, regardless of your personal judgments about their choice. And I think one thing I want to leave you with here before we wrap up about this one is just that, you know, how do you then communicate that back to your partner? And sometimes obviously office politics and dynamics can be tricky. But you know, there can be gentle education that can be done to be like, hey, I saw this patient that you had seen, you know, I want to talk to you about that. Like, you know, she said that you only offered her an IUD, like, you know, kind of getting into that a little bit and being like, please refer to me if like you don't feel comfortable with these patients, or however you see fit to address that. Okay, so we're gonna wrap with just like 2 minutes to spare. But essentially our big takeaways again from today, would just be to avoid coercive counseling first and foremost, check those biases, go back to the values clarification that we sent with the invite, and then support them in what they need and where they're at, no matter what that is for their reproductive care. Okay, we have probably just like a minute for some questions. I'm sorry we didn't leave a ton of time, but thank you all so much for participating in our discussion. It was wonderful.
Thank you so much, Jen and Danelle. And for those who would like to claim CME credit, we will take a moment and talk about how to claim that, but we will also be sending an email if you need to hop off quickly before we get to that portion. But I did want to leave a few minutes for questions. If anyone has any, please do feel free to unmute yourself or put them into the chat and we can read them out. I'm going to switch over to my CME slides while people are thinking about their questions.